Good morning. Hi, if you'd like to start taking your seats, now would be a great time to kind of get cozy, find a place you want to sit. I'm Dr. Valerie Liao, and it's my privilege to welcome you to the Medical City Weight and Wellness Brunch. I'm joined here today by three other physicians. I have Dr. Bell over here in the back, and if he'll raise his hand, you'll see Dr. Bell, Dr. Sutker, and Dr. Henke. We're also joined by one of our dietitians, Mina, and we'd like to thank our executive chef, Miguel, for providing this fabulous spread this morning. I'm sure all of you have had a little chance to taste it, and if you haven't, please help yourselves. So, I am a medical weight loss specialist. I'm an internal medicine physician, but I also have certification in obesity medicine. Are you able to hear me? Barely. Okay, how about like this? Is that better? Okay, great. I'm Dr. Valerie Liao. I'm an internal medicine physician, and I also am board certified in obesity medicine. I am the medical director of non-surgical weight loss here at Medical City. As you know, the surgeons that are joining me here today will be talking about surgery, but I'm really going to be talking about the non-surgical approach to things. This is just going to be sort of a broad overview of weight loss myths and tools. And as we all know, there's no such thing as one size fits all. So you're going to hear some things from me that may or may not apply to you individually. And if you were to ask Mina, for example, she would give you specifics on individualized plans, and any of our doctors here would also give you specifics on individualized plans, because we believe that weight loss is a customized, specific issue, and every person has to have it tailored to themselves. So I'm going to talk about weight loss myths and tools, and I'd like to start with a story. Once upon a time, there was a girl named Jennifer, and she didn't remember having any weight issues as a child. Then she went to college, and she gained the freshman 15. And so she decided, I am going to go on a diet, and I'm going to exercise, and I'm going to eat salad and tuna. And of course, she lost the weight, and she was fine. And then she started her first job, and then she gained 10 pounds because she got kind of busy. And then she met a nice guy. They decided to get married. She dieted, she exercised, she lost the weight again. And then she kind of got busy at work and gained 20 pounds, but that was okay because, she was comfortable in her skin. And then she got pregnant with baby number 1, and she gained 40 pounds. And then she was way too busy to diet and way too busy to exercise. And then along came baby number 2. And what do you think happened then? She gained another 50 pounds. And so here we are, several years later, and Jennifer is 40 years old, 5'3", 200 pounds, with 2 beautiful babies who are finally in school. So it's Jennifer's opportunity to try to get healthy, try to get more fit, and try to get back into the person that she believes that she ought to be. So what does she do? She turns to the world's most definitive authority on everything, Dr. Google. She goes to the internet, and it gives her a lot of messages, and they're overwhelming. So how does she know what to believe? Well, one of the messages that you get from Dr. Google is that fat burners work better than prescriptions. How can this be? Well, there is actually a grain of truth to this. Is everyone able to hear me? I'm seeing a little bit of consternation in faces. Okay, sorry about that. So why is it possible that these pills can possibly work? Some of them have a placebo effect, and that's enough of a Kickstarter for you to be able to get into good diet habits and good exercise habits. But the scientific studies that supplement companies cite are usually their own scientific studies, and we don't know if these results can be reliably reproduced in any other setting except in their company facilities. It's much better if Jennifer decides to get her information from scientific studies that are published in the medical literature, in peer-reviewed journals, and by scientists whose research is not backed by large money-making corporations. So, for example, in a 2011 study published in Obesity Reviews, the authors evaluated a long list of supplements, including caffeine, green tea, carnitine, CLA, forskolin, chromium, kelp, and fucoxanthin. And in this review, based on medical literature, caffeine and green tea actually had data to support their fat metabolism enhancing activities. A study in 2004 in the Journal of Clinical Nutrition looked at a group of 180 people taking CLA, and they compared the ones taking CLA pills to the ones taking CLA syrup. They gave them diet and exercise tips. They had them keep food and activity logs, and at the end of the year, the people on CLA lost 4 pounds. Not sure if that's exactly the sort of weight loss that you're looking for if you're here this morning. Then in a 2003 study in the Journal of Lipid Research, there was a large review of 13 different studies that did not prove that CLA caused any weight loss. And actually there were concerns that it caused lipodystrophy, which is a term for an abnormal form of fat deposition that can be a little bit disfiguring. Jennifer also has over 100 friends on social media, some of whom she hasn't seen in years, except on Facebook maybe. And everyone posts the perfect story of their perfect life and their perfect weight loss, but no one brings up whether their perfect weight loss was artificially enhanced by Photoshop. In addition to seeing ads for fat burners online, Jennifer also notices a lot of ads for restaurant foods. These ads are confusing because we're led to believe, for example, that one hamburger is a serving size for exactly one person. Interestingly, when the average hamburger size in 1955 was about 4 ounces, the average American man's weight was 166.3 pounds. And in 2006, when the average hamburger size had grown to 12 ounces, the average American man's weight had also grown to 194.7 pounds. If we keep going this way, what would we predict for 2050? Or, taken another way, in the 1950s, here is an average serving of a soda, a burger, and fries. And what did it do? It went up. And what happened to the average American person? I think you can see those little pictures on the bottom. So how are we supposed to know what the right portion size is? Our plates aren't helping us. If you look over here in the 1960s, we had an 8.5-inch plate. And over here in the diagram, you can see that the weight of the average American man and woman was lower. And then up in the 2000s, the plate increased to 11 inches, and you can also see on the graph that the weight increased as well for average American men and women. That was just in 2000. Now, here we are. Our average dinner plate size is about 12 inches, and if you go to a restaurant, the average dinner plate size is about 13 inches. And how do we eat? Most of us eat with our eyes. We look at the plate, we put food on the plate, we figure that's how much we ought to be eating. And then a lot of us have also been brought up to eat everything on your plate. And so what's going to happen there? Well, of course, Jennifer also has a lot of well-intentioned family members, and they all want to give her advice. And the advice that a lot of them give is, you need to eat 6 small meals a day. Well, that's not always right. And studies in the Journal of Nutrition in 2001 showed that people who were given mandatory snacks would actually consume slightly fewer calories at the next meal, but not enough to offset the extra calories of the snack itself. So if you look at it, throughout the course of the entire day, people would end up consuming more calories. Other studies have supported this also. Jennifer also wanted to sign up for a gym, since so many of them have special discounts for the new year. But she was really intimidated because she didn't know where she was going to find 2 extra hours every day to drive to the gym, work out for an hour, take a shower, and then drive back home. How many of us have that much extra time in their day? Probably not a lot of us. Well, the good news is that multiple studies show that exercising in 10 to 15-minute intervals throughout the day to a total of 30 minutes, 5 days a week, is beneficial to weight, cholesterol, and aerobic fitness. And let's not forget that exercise also helps to mitigate stress. So if you don't have 2 extra hours in a day, that's okay. You can have 10 minutes of walking in the morning, 10 minutes of walking at lunch, 10 minutes of walking in the evening, that all adds up and it doesn't wear you down. It's frustrating to Jennifer when she thinks about how much time, money, and effort it's going to take to lose weight with diet and exercise. She's done it before, and the 5 words that she hates the most in the English language are, "I gained it all back." She wants to lose weight now, and she wants it to be permanent. Our surgeons are going to talk about surgery for weight loss, and in my medical office, I have patients who lose 10 to 20 pounds in a month with no medications. I also have patients who lose 1 pound on 2 or 3 medications. Medications are not magic. They can change your hunger sensation, they can help with your motivation and your mindset, but they're not magic. They don't just melt things off. They're just another tool in the toolbox of weight loss. So if the person using the tool isn't maximizing the use and using it correctly, they're not going to get the best benefit. It's similar to trying to use a pair of nail clippers to screw pieces of wood together. All calories are created equal is the biggest myth of all. Jennifer hears that a calorie is a calorie, but I think it's very evident, even to small children, that the nutritional content of chocolate cake is not the same as the nutritional content of fish and broccoli. And we all know what it's like to eat hyperpalatable foods. What about that chemically engineered bag of potato chips where you can't eat just one? With certain foods, it's very hard to stop eating, and with others, it's very easy to stop when you're full. I've had a lot of patients tell me that they couldn't stop eating cookies, but I have not had a single one tell me that they couldn't stop eating steak or green beans. So, which weight loss tips are worth following? Here are 10 tips that I would offer to Jennifer. Number 1, watch your serving sizes. Get out your measuring cups. Measure your food. Teach your eyes what a serving size should look like. Don't go with what you see at the restaurant. Don't go with what your plate size is. Teach your eyes. Different foods have different serving sizes. So, for example, a serving size of meat is how big? Deck of cards. How about a serving size of green leafy vegetables? 1 cup. So if you're not sure, and if your food is not coming from a box, a bag, or a package that has a nutritional label on it, then take out your smartphone, look up the serving size. Get familiar and get comfortable with what those serving sizes ought to be. Number 2, no snacking. Number 3, track your food and activity. You can do this with pen and paper if you like the old-fashioned way, or you can use any of several apps that are available on smartphones or a wearable electronic device. One of the reasons that we recommend logging food and activity is because studies show that it actually makes a difference in what you decide to eat. For some people, they just don't want to bother with pulling out the measuring cups, looking up the serving size, and then writing it down. And so then they just don't eat it. For other people, when they see how many steps they took yesterday, they know today they can take more, and they increase it little by little. Number 4, give yourself good reminders of your goals. I've seen a lot of kitchens and households where there are reminders to people to eat junk food all day. There'll be a bag of chips on the counter, there's a cookie jar on the other counter, and then the kitchen towels have pictures of pizza and cupcake with cute little sayings. So what are those reminders telling people to do? Go ahead and have a little bit of this. Well, maybe that's not always the best idea. How can you counter that? Well, let's say you wanted to lose weight for a beach vacation. Take a picture of the beach, put it on your pantry, put it on your refrigerator. Every time you're reaching for that door, you're going to see the picture of the beach and you're going to say, maybe I don't want that extra cupcake. Or if that's not the way you want to do it, you can take a bright orange Post-it note, put it on your TV, put it on your remote control, put it on your cell phone or your laptop. Let it be a visual reminder to you of the behaviors that you want to use, whether it has to do with food, activity, or even motivational sayings. I can do this. I can do this. Whatever it is, let that bright orange Post-it note be that reminder for you. Some of you may have also heard about when people are trying to quit smoking and they'll take a little rubber band, put it on their wrist, snap the rubber band whenever they're tempted to smoke. You could do the same thing. Other people can set timers to go off every 30 minutes while they're working on their computer so that it'll remind them to get up, walk around for a little bit of time. Simple things that can help you to remember the best ways to keep yourself healthy and fit. Number 5, minimize processed food and have less drive-through eating. I think we probably all know people who eat all of their meals at restaurants every day. Breakfast is McDonald's on the way to work, lunch is Taco Bell because it's close to work, and then dinner is special because you get to go to any of 12 different restaurants somewhere on the road between work and home. But what does that mean? That means portions that are not under your control, food that's cooked by someone else and you don't know what was put into it. That's not going to be as healthy as when you know what's in your food because you're the one who put it together. The less processed, the better. Number 6, set SMART goals. A lot of you have probably seen this acronym before. SMART stands for specific, measurable, attainable, relevant or realistic, and time-based. So, for example, you say to yourself, I want to lose 40 pounds. Well, when do you want to lose that by? Do you want to lose that in a year? Do you want to lose it in 8 months? If it's 8 months, break it up. 40 divided by 8 is 5. So, every month you should be losing 5 pounds. That's very specific. You can measure it by getting on the scale. Because it's time restricted, then you can look back at the end of each month and say, did I accomplish this goal? And if you did, that motivates you to continue. If you did not accomplish your goal, then you can problem solve. Number 7, make it easy for yourself. How can we make this easy? Well, a lot of grocery stores these days have pickup and delivery services. So what do? You can just go online, pick your foods, give them your credit card number, drive to the store. They'll load it up for you. Is this a bad thing because you didn't get all those extra steps in the day? No, it's a good thing because you also didn't get 4 extra bags of chips, that extra cheesecake, that extra 12-pack of soda. So this is a way to help control what you're bringing into your house because the battle starts at the grocery store. What are meal replacements? Those are going to be shakes or bars that you can purchase that will substitute for an entire meal. But it helps you because it's a lot less prep, a lot less cleanup, and you're not tempted to overeat. Another factor that people can consider is intermittent fasting, which also doesn't have prep or cleanup. And because the internet is so prevalent these days, you can use restaurant menus to help you make smarter choices before you go to eat out. Take a look at the menu online, see what it says. See which items there are going to be more compatible with your diet plan. Number 8, reward yourself. We all like to reward ourselves, and I hear people frequently talking about, when do I get a cheat day? Well, the other thing you can consider doing is using non-food rewards. When you get to your goal at the end of the month, maybe that means that you're going to splurge on a little something, treat yourself, but it doesn't have to be with food. Number 9, avoid distracted eating. Don't eat in front of the screen. Sit at a table. See your food, smell your food, taste your food. Be able to actually identify what's in there. If you're sitting in front of a computer screen, a TV, an iPad, a cell phone, how many times are you very aware of what you're eating and how much you're eating? And last but not least, number 10, don't eat if you're not hungry. Think of HALT BS. That stands for reasons that people eat. They eat when they're hungry, when they're angry, when they're lonely, when they're tired, when they're thirsty, or sometimes they're just bored or stressed. So what can you do? If you're feeling a little bit hungry and you're not sure, drink a cup of water, walk around for 10 minutes, come back. If you're still hungry at the end of that time, then sit down at a table. Eat consciously, eat mindfully, know exactly what you're eating, and then let your mind also realize that you're eating, not just your tongue telling you what to do. So coming up with the best plan for how to approach weight loss can be overwhelming for anyone, not just for Jennifer. If you'd like help making a plan, come to see any of us. We're here to help. I'm also going to add that if you have any questions, we'd like you to hold your questions until the end of our presentations so that you can raise your hand and specifically address whichever doctor you'd like to answer your question, or also Mina, our dietitian, is over here to help answer questions for you. Thanks very much. I'd like to introduce Dr. Sutker next. He's going to be giving us a discussion about obesity.
All right, welcome everybody. So the next part of this, between me and Dr. Bell and Dr. Henke, is sort of a three-part discussion. I'm going to talk a little bit about what happens before surgery. Dr. Bell is going to talk about surgery itself, and then Dr. Henke is going to talk about what's after surgery. So it's sort of all a continuum. So what I'm going to review is we're going to talk about, well, how do we define the disease of obesity? We'll talk about what the body mass index is, and then we'll talk about how it's just a big problem in society. We'll talk about why is the disease of obesity a problem, and then we'll talk a little bit more about the different treatments that we have. So obesity is a chronic disease. It affects every aspect of our body. It has psychosocial consequences, it has mechanical consequences, it has metabolic consequences. The typical term that we use to define obesity, and once again, it's not a catch-all term, it's not perfect, but it's typically what's used by the government, by insurance companies to help sort of stratify people, but it's called the body mass index, or BMI. And this is a value that's calculated based on your weight and your height. That's just the formula there. So a normal weight is a BMI of about 18 to 25. You're considered overweight if your BMI is 25 to 30. Obesity is anything over 30. And then as we get into talk about surgery, almost everybody with a BMI of greater than 40 and a lot of people with a BMI over 35 are considered candidates for surgery. There's other values that people use like waist circumference. So once again, no one term is perfect for how to define obesity. Everybody has different body styles, but these are kind of the good way to compare as much as possible. So this slide's really busy, but basically what it shows is your weight on the top row, and then, all right, so weight is on the top row here. This is your height here. So let's say you're 5'6", and you weigh 250 pounds, your BMI would be 40. So everybody in the pink and most everybody in the red would be considered a candidate for surgery. And I'll give everybody a chance to kind of look if you can actually read the little small numbers. All right. So, obesity is a problem not only for individuals, but in the society as well. So the government has wanted to track this over the past 30 years. So they called people on the phone and they said, what's your height, what's your weight, and they calculated BMI from there. So this is looking back to 1990, and the lighter blue states had less than 1 in 10 people that were considered obese. The darker blue states had 10 to 15%. And just watch as the colors change as we go over time. So this is 1990, so this is about 30 years ago. So now we even have a new category, 15 to 20%. So more and more dark blue. Now we have a new category, 1 in 5. Now we have 1 in 4. Now we have 1 in 3. And the most recent statistics we have from 2010 show that every state has at least 1 in 5, if not more, people that are obese. And if you kind of look at it, it actually looks like the growth from a viral illness, where it kind of starts in the southeast and the Midwest and has kind of grown from there. So just to compare, 1990 up on the top left, lots of blue, somewhere between 10 to 20% of the population. And then now, 2010, at least 20 to 30% of the population that are obese. So it's not just you as an individual, it's everybody. Everybody knows someone, has interacted with someone that is struggling with the disease of obesity. So the question is why is obesity a problem? And it's because it affects every single system in your body. So your heart, your lungs, your GI tract, your urinary tract, your nerves, your psyche. And specific problems that we know are associated with obesity include things like high blood pressure, heart failure, heart disease, diabetes, high cholesterol, arthritis, sleep apnea, asthma, acid reflux, urinary incontinence, strokes, dementias, depression. So all of these things can be directly tied into obesity. One of the other things that can happen is actually obesity can put you at risk for developing cancers. And these 13 specific cancers are tied directly into obesity, and those include things like thyroid cancer, breast cancer, colon cancer, ovarian cancer. So being obese puts you at risk for all of these things. Just for instance, just talking about surgery, how do we change that? Well, people who have surgery have a less incidence of these cancers as we get rid of fat. And ultimately, what all of this means is obesity reduces your life expectancy, meaning obesity actually takes years off your life. The numbers on this scale probably really aren't that important, but I think the trend is. And so the way this scale reads is as we go up, this is increasing BMI, and this is years of life lost. So as you have a higher BMI, you have the potential to lose more years off of your life. And so, once again, what happens when we change that? So what this is actually looking at the mortality, the death rate in patients who have obesity and in patients who had surgery. And so what this is looking at is the dark black line of people who had surgery. It's a little bit higher in the first part, and that's related to risks of surgery, which Dr. Bell will talk about. But as you go out over time, people who lose weight with surgery have much less mortality because we're affecting all of these medical problems that are associated with being obese. So, why do we actually need to treat it? Why can't people just do this on their own? And the answer is, it is really, really difficult to lose weight. And they've actually studied this. So let's just say you're a woman, your BMI is 40, and you want to just lose weight on your own. Well, the chances of doing that, getting from your current BMI to a normal weight, if you want to do that on your own, it's 1 in 700. If you're a man, it's 1 in almost 1,300. So it's not a willpower issue. It's not a, I'm trying really hard. It's just our bodies have mechanisms designed so that we don't lose weight. So that's where medicines, that's where treatment comes in, that's where surgery comes in, is because our bodies fight losing weight. So when we talk about treatment, what does it involve? It involves nutrition, it involves activity, it involves behavioral therapy, it involves medications, and then ultimately it involves surgery. We're not going to necessarily talk about all of these in great detail, but we'll kind of review a little bit. So kind of building off of what Dr. Liao said, there are lots of commercial diets out there. And when patients come to see us in the surgery clinic, the vast majority have tried 2, 3, 4 different diets. And everyone is moderately successful, losing 15 to 20 pounds, but then as soon as you stop the diet, getting 20 or 30 pounds back. Or losing 50 pounds, but gaining 75 pounds back. So we just have data that shows for people who really need to lose a lot of weight, like our bariatric surgery patients who need to lose 75, 100, 150 pounds, diets just don't work great. So what this study did is they said, we're going to assign you to one of these 4 diets. So Atkins, Weight Watchers, Slim Fast, Rosemary Conley. And then when it says control group, those are people who didn't have one particular diet. And they said, come back and see us in 6 months. And at 6 months, if you look at the averages, so this black line here, it didn't matter which of the diet they were on. People lost about the same amount of weight, about 15 to 20 pounds. And the people who weren't on a diet, they didn't lose any weight at all. And so, okay, that's not bad. But what we want to see, we don't want to see 6-month weight loss. We want to see 3-year, 5-year, 10-year. We want to see people lose the weight and keep it off. So in this study, they didn't do commercial diets, but they varied the nutrients in people's diets. So either lower high fat or lower high protein. And they actually gave pretty intense sessions. So they had people seeing counselors and group sessions and individual sessions and seeing people pretty frequently. And so basically, they were giving people as much support as you could possibly give someone to help them lose weight. And so the way this scale reads is this is actually increasing weight loss as you come down. So at 6 months, people lost the most amount of weight. But even with all the help in the world that people could get, at 12 months, at 18 months, at 24 months, people gain the weight back. So that's why we know just diets don't work that well. And the other interesting thing about this is if you look at the clusters, it didn't matter what the diet consisted of, whether it was low protein, high fat. All the diets, people lost about the same amount of weight. So what's next? If diets don't work great, then what about medicines? And so the problem with medicines is, and what I have highlighted here in the yellow, people will only lose about 3 to 5% of their body weight, which for most people is about 10 to 20 pounds. And once again, like we talked about, the patients that we're seeing don't need to lose 10 or 20 pounds. They need to lose 100 or 150 pounds. So medicines don't work great for that. The other problem, and this is an older slide, we have some newer medications that we'll talk about in a second, but a lot of these older medications were very poorly tolerated by people. They cause dry mouth, they cause chase changes, they cause bloating, they cause diarrhea, and so really people just couldn't tolerate them at all. We've got a few new medicines out there. The most common ones that we prescribe are Qsymia and Belviq. They have a little bit better weight loss, maybe about 8 to 10%. They're better tolerated. They have a lesser side effect profile. But for our patients, once again, It's not just 15 or 20 pounds that you need to lose. It's more than that. And so I think these medications were good as adjuncts, as addition to your treatment. Because what happens after the first year is a lot of times your body adapts to them where they're no longer effective. So there's certain medications you take for 6 months, then you stop them for 6 months, then you take them for 6 months, and then you stop them, because otherwise you lose your effect. All right, so that brings us to surgery. And Dr. Bell will talk about the details a little bit, but when we're talking about surgery, everyone undergoes an evaluation to say, are you an appropriate candidate? And the reason for that is we want to make sure that you're going to be successful. We as surgeons like to operate. This is what we do. We don't like to operate when we don't see good results because it doesn't benefit the patient at all. We really want to see people be successful. We want them to lose weight. We want them to stop their diabetes medications, et cetera. And the other thing is we want to just make sure that surgery is being done safely. We can do a very beautiful sleeve or a bypass, but if you have a heart attack, that has not benefited you at all. So we want to make sure that you're being safe. And so when we talk about requirements for getting into the operating room, most of these are defined by your insurance company or recommendations from government agencies or surgical societies. And those include things like evaluation by your primary care doctor. We as the surgeon can say, you look like a great candidate, but most people want to have a second physician saying, we also agree that this is a good idea for surgery. Everyone needs a nutritionist evaluation. So learning what are you eating now? What can you change? What is the diet going to be like after surgery? And this is typically the rate limiting step to getting people in the operating room because every insurance company requires something else. Some companies require 1 visit. Some companies require 6 visits. Some companies require 2 years of weight loss. So it just varies. And then the last thing is everybody gets evaluated by a mental health professional like a psychiatrist or a psychologist, and we're looking things like for eating disorders or substance abuse disorders or worried about self-harm, because ultimately we want you to make sure that you're going to be successful after surgery. And then other things include things like blood work, ultrasound of your liver to look for fatty liver disease, an ultrasound of your gallbladder if you have one to look for gallstones, and then heart testing and lung testing, et cetera. And then also just to make sure, are you up to date with all of your general health maintenance? So, the timeline would be, it's great that everybody's here. If you're interested in taking the next step, we'd have you contact our coordinator. They would look at your insurance benefits. They'd schedule you for an appointment. We'd get all the tests done, and then we'd have you come back to talk about surgery in more detail. So, with that, I will pass it off to Dr. Bell. He's going to talk to you about the different surgeries in some more detail.
All right. Well, my name is Chris Bell. I'm one of the general surgeons here. I also do bariatric surgery, and I'm going to be speaking this morning about different options for surgical weight loss, and we'll talk a little bit about the types of procedures and a little more specific about the operating room and what to expect. So Dr. Sutker talked a little bit about indications. I'll just review that again. Body mass index, generally we think a patient is a candidate for weight loss surgery if their BMI is over 35 with medical problems such as diabetes, high blood pressure, joint pain, high cholesterol, things like that. Or you could have a BMI of 40 without medical problems. And it's really satisfying as a surgeon to see a lot of these medical problems go away after surgery. So one of the things I really enjoy is seeing patients back in the clinic and they'll say, I'm not taking insulin anymore, or I'm not taking 3 blood pressure medicines anymore, and that's because with weight loss, a lot of those things get better. We talked briefly about pre-op evaluation. Dr. Sutker went over that. So generally, we want to make sure that a patient is medically fit for surgery, that there's not any cardiac issues that might arise around the time of surgery. And so we're very careful about making sure that patients are good candidates for surgery. And we talked about the testing that we do prior to surgery. The main procedures that we do here at Medical City are the laparoscopic sleeve gastrectomy. I would say that's probably the most common one. Another option is the Roux-en-Y gastric bypass. A new procedure that is becoming more prevalent is the intragastric balloon. And there are several types of intragastric balloons, and I'll show you a picture of one of those in a few minutes. And gastric banding used to be very popular. That's not done very much at all in the community, but we still have patients that we follow in our clinics that have had bands, and so that procedure has been successful in the past, but is not done as much anymore. I think because the sleeve gastrectomy has been so successful in allowing weight loss. The advantage of a sleeve over a band is that with the sleeve, it does not require adjustments, and so that's one nice thing for the patients at follow-up. This is a slide that basically shows the prevalence of sleeve gastrectomy, and as you can see, at about 2012, the sleeve gastrectomy overtook gastric bypass as the main weight loss procedure in the United States. Let's talk a little bit about the operation itself. It does require general anesthesia. So general anesthesia means that a patient is completely asleep with a breathing tube in. Most of the time, these procedures take about an hour and a half to complete, sometimes a little bit longer depending on if a patient's had surgery before. There may be scar tissue that would take longer, or if you've had another procedure such as a band and you're going to a sleeve, that operation will take longer because there will be more scar tissue within the abdomen. One of the things that we all do is we really recommend patients getting up and walking right after surgery, and that is something that really helps patients get out of the hospital sooner. It helps them feel better, and so getting up and walking is one of the things that we all emphasize in our patients. Most of us do an upper GI on postoperative day number 1, so the day after surgery, we have our patients go down to the x-ray department and we get an upper GI, which is a contrast study, and so we like to check the anatomy of the stomach and make sure everything looks good, and so that's one thing that we do here at Medical City. Patients usually can go home after they can tolerate liquids, and we have a dedicated ward for weight loss surgery. And I'd like to introduce Shay Dorsey, who's here in the back. She's our bariatric coordinator and does a great job with our weight loss patients, and we certainly appreciate her. One of the really exciting things that we have developed at our hospital is a program called Enhanced Recovery after surgery. And so we have developed a strategy to prevent overuse of narcotics after this type of surgery. And so this has allowed us to have patients go home earlier and on less medications, and they have lower pain. And so that's something that is very exciting for all of us. We started this about 6 months ago. So before the surgery, one of the things that we do, and I'll explain why we do this in a few minutes, we start patients on a liquid diet with a protein supplement. And what that does is it reduces the size of the liver. And so, as you all may know, the stomach is located behind the left lobe of the liver, and so we really want that liver to be as small as possible because we have to actually retract the liver to operate on the stomach. And so this makes the operation easier for the surgeon. And so we generally put patients on a liquid diet for about a week prior to surgery. And then after surgery, Dr. Henke will talk about this, I'm sure. We start patients on a liquid diet, and it's a very slow progression towards a regular diet over a period of about a month. And obviously, there are vitamin supplements that we recommend and have patients take. So let's talk a little bit about how the surgery is done. So generally speaking, these operations are done laparoscopically. And so what does that mean? Well, that means that the surgeon will make very tiny incisions on the abdomen rather than making a large vertical incision. So the small incisions allow for patients to recover quicker. It's less painful and cosmetically nicer compared to a large incision. And so with laparoscopic surgery, we use carbon dioxide gas to inflate the abdomen so that we have room for the instruments to move within the abdomen. And before the patient wakes up, we let that CO2 gas out. And so that is how it's done. You can see in the picture here, the surgeon operates on a video screen. And so we're looking at the anatomy by way of a laparoscope, and we see that on a screen. Another type of laparoscopic surgery that some surgeons use is called robotic surgery. And once again, this is a technique that we use with CO2 insufflation with small incisions. And the surgeon is in the same room as the patient and controls the robot by way of a console. And so that's another type of laparoscopic surgery that we use for weight loss surgery here at Medical City. This is some of the instrumentation that the Da Vinci robot allows us to use. And one of the nice things about these instruments is that they're like your wrist. So they're able to move like a human hand. And so it facilitates suturing and manipulation of anatomy and things like that. So you may hear more about that if you visit a surgeon in the future. But it is a type of laparoscopic surgery. Okay, let's talk about what a gastric bypass is, what does it look like, and also a sleeve gastrectomy. And so on the picture on the left, this is a gastric bypass. And so basically what is done is the small intestine is rerouted to the upper stomach. And the upper stomach is actually disconnected from the lower stomach. And so what this allows for is a reduction in the size of the gastric pouch, and so patients are full with a small amount of food, but it also bypasses the duodenum where a lot of carbohydrates are absorbed. And so it's a very powerful weight loss operation. It has been around a long time, and patients have done very well with it. The sleeve gastrectomy is the picture in the middle. And that is an operation where part of the stomach is removed. And the difference between a gastric bypass and a sleeve is that the main difference is that on the sleeve gastrectomy, no part of the intestine is operated on. It's only on the stomach with the sleeve gastrectomy. So these operations are done with staplers, surgical staplers that allow a sealing of the edge of the stomach. And basically, we take out about 70 to 75% of the stomach with the sleeve gastrectomy. One of the things to point out between bypass and sleeve gastrectomy is a gastric bypass is reversible. It's not easy to do that, but with a sleeve gastrectomy, that is not reversible. So once that stomach segment is taken out, you cannot put it back in, although it's extremely unlikely that patients would ever think about reversing a sleeve gastrectomy because they do so well with weight loss and reduction of medical problems. But I just wanted to point that out. As mentioned, we don't do lap bands much anymore, but that is what a lap band looks like on the right. Okay, so sleeve gastrectomy works by reduction in the size of the stomach, and so this operation is designed for you to eat regular food. You're just full with a smaller amount of food. And there's also a reduction in the hormone called ghrelin, which is produced in the part of the stomach that's taken out. A Roux-en-Y gastric bypass also restricts the size of the stomach and alters the intestinal absorption of carbohydrate, as we discussed. This is a picture of an intragastric balloon, and so the way that this works is that a balloon is placed inside the stomach, and so this is done without any incisions, and it occupies space within the stomach so that you are full without having a lot of food. And so basically that's how it works. The one thing about this procedure is that it is only good for 6 months, and so the balloon cannot stay in permanently, and it has to be removed at about 6 months. And so that's one consideration. But the hope is that once patients have lost weight with it, their healthy lifestyle will be kick-started, and that will get patients on their way to long-term weight loss with diet and exercise. I put this slide in here just to show that the stomach is behind the liver, and so we have to actually lift the liver up to operate on the stomach. And so the one reason we put patients on a liquid diet prior to surgery is to really reduce the size of the liver. We want all the glycogen stores to be out so that the liver is nice and thin, and so the operation can be easier, which allows us a better ability to see the anatomy. This is just a slide showing that the gastric bypass has a little bit stronger reduction in weight over the first year basically you'll see about a 15% reduction in BMI, a 15-point reduction in BMI over the first year versus a sleeve gastrectomy, which averages about 10-point reduction. And so, for example, if your body mass index is 40, at about a year, it would be expected to be around 30, hopefully less than that after a sleeve gastrectomy. This is a slide that I added just to show that eventually your weight will plateau, and so after weight loss surgery, patients will ask, will I continue to lose weight? I mean, will it ever stop? And yes, it does. It plateaus off after a period of time. So that slide shows that. Let's talk a little bit about risks of surgery. One of the big risks that surgeons used to be very concerned about in the years past was a leak of one of these operations. And so, as I mentioned, we used to see that occasionally. I think it's much less common these days that you would have a leak after an operation, but it still is a risk, and it's important to know that. Within the stomach itself, patients can get ulcers after a bypass, especially if patients are taking NSAIDs and other medicines that can cause them. Gallstone disease is also a risk, and that is because with rapid weight loss, patients can develop gallstones, which is one of the reasons that we like to screen patients for gallstones prior to surgery. And that is true for either operation, the bypass or the sleeve. You could definitely develop gallstones with rapid weight loss. There are some specific complications that can occur due to bypass, and one of them is called an internal hernia. That is extremely rare, but surgeons who do weight loss surgery will know to look for that if that ever happens. And dumping syndrome is something that can happen with both operations, which can be prevented with proper diet. Okay, and just some benefits of weight loss surgery. You know, we have reduction in medical problems. As mentioned, patients are able to get off their medicines, which is outstanding. Patients have a better quality of life. I think they feel like exercising more, they're more mobile. I think their energy levels go up. As Dr. Liao said, this is a tool for weight loss, but it does require a lot of effort on the patient's part and the doctor's part, and follow-up is very important. And so I'll hand it over to Dr. Henke to talk about postoperative care, and we'll answer questions at the end.
I'm our last speaker today, so I'll try to bring us home and go through managing after surgery. And so when patients have made the decision, they've jumped in, they've gone through with surgery, we look at how are we successful after surgery. So lots of patients will come in, and before we even start with surgery, you know, you hear the story of, well, I have someone that goes to my church, and they had surgery and they just look sick all the time. Or I have a friend at work and they had surgery, but they regained all their weight. Well, how do we prevent that? And that's where follow-up and management after surgery comes in. And so everyone's schedule look a little bit different than this, but this is kind of my typical post-op follow-up. And so we're going to see it 2 weeks after surgery, 6 weeks, 3 months, 6 months, a year, 18 months, and 2 years. And then we want to see each other for at least 5 years after surgery. I have lots of patients who had surgery with myself or my former partner or other surgeons who come and see me who had surgery when I frankly was still in medical school or undergraduate, but we're looking for long-term success. And so obesity is not a short-term disease process. This is a long-term disease process. And lots of things happen in our lives. You know, we have the good times where I've had patients start families and come in and, you know, looking to lose weight after a baby, or, you know, unfortunately lost someone. Stressors in life cause big fluctuations in weight and appetite and how we go about. So we're looking for long-term success. So how do we do this, and what are we looking for? How do we prevent you from looking sick or regaining weight? One of the primary things we're doing in all these follow-ups is we're going to monitor your labs. We're going to look at vitamin levels. Vitamin levels are not something your primary care physician is frequently monitoring. This is not something that is on our standard list of, at this age, we are looking for this. Vitamins do not fall on that. We're checking your cholesterol or prostate antigen for men, lots of different things, but vitamins aren't on that list. And so Patients who have surgery and disappear, oftentimes they look sick because they don't have these vitamins. You're going to have an inadequate intake a lot of times, either from a sleeve or malabsorption from a gastric bypass, that we need to look at vitamins. And these are some of your key vitamins that we look for and see deficiencies in. B12, iron. Iron's responsible for our blood synthesis, so you become anemic, feel fatigued. B1, thiamine, and vitamin D. I can tell you right now, lots of people walking around Texas have vitamin D deficiencies. We have plenty of sunshine here, but we go from our cars to work, cars home. We're not having a lot of sunlight exposure. And so we need to get them in through our food. And yeah, it's great if you can eat all these foods, but we're going to supplement with vitamins. And if you don't get these vitamins, you're going to have deficiencies in neurologic function. You're going to get numbness in your legs, things like that. You're going to start getting sick and immune system problems. So we need to follow these. And that's why some patients that you'll see, or you know that person that had weight loss surgery that looked kind of sick, well, they're not getting these vitamin levels checked. Protein. Every time you come in, we're going to talk about where is your protein coming from. This is your primary source. Our bodies do not synthesize protein. Our bodies need protein ingested to start building, or we can break down our muscle. But where do we get our protein from? What are our sources? So good sources of protein you can see over there. Lots of lean meats, whether it is chicken, whether it is fish, beef, pork. You know, beef kind of gets a bad reputation, but it is okay, especially in the portion sizes you're going to be taking in. You're going to get this. Number one culprit I hear from patients, peanut butter. Peanut butter is advertised as a great source of protein, but when you're looking to get 25 grams of protein, you can have some lean beef and stay under 200 calories. That's great. You can have 7 tablespoons of peanut butter and get nearly 700 calories. So peanut butter is kind of a misnomer that we don't want you having that. That's a lot of fat, a lot of sugar content. You notice on that list I did not put protein shakes. Now don't get me wrong, Premier Protein is great, and I use that for a lot of my patients pre-op. You know, Dr. Bell talked about the pre-op liquid diet, and we're going to have a stage diet after surgery. Yeah, you're going to be supplementing with protein shakes and things to get your protein in, and it allows stomach healing and allows you to transition. So early use of shakes is fantastic, and that's what we're advocating. That's what we want you to do. I have a lot of patients that, especially in the first year or 2 years after surgery, they are very good on the go, and so breakfast is a struggle for a lot of people. So you get up in the morning, you want to get going, you grab a protein shake, and as long as it sits and lasts with you, that works perfectly fine, and those are okay. It can work as a snack, and that can be okay as long as it sits and satisfies your hunger. That's okay too. But what we really focus on is healthy meals. Those will sit with you. Those will last longer. Our bodies, we have these things for a reason. We're meant to chew. Our bodies want to chew. We don't have our jaws wired shut. We want to chew. And so solid long-term, we want protein sources and we want healthy meals, not to subsist on protein shakes. It's a recipe for failure if we do that long-term. So where do we look at for snacks? What types of things do we look at, and how do we manage and stay on track? So raw vegetables are a great source. Now granted, we're not getting our protein in those, but we're getting some of our nutrients that we need. They're going to fill you up. You just don't have much space. They're going to fill you up quickly. Low-fat string cheese, sharp cheddar, I have found since I've lived here, is very popular in Texas. That is not a low-fat cheese, sorry. But we're going to look for low-fat cheeses. Fruits. I tend to advocate for dense fruits because, again, you have a small area. The more dense a fruit you bring in, that brings in, berries and things have great antioxidants, and small portions are okay. But you can also take a little bit more and get higher calories in with some of the berries and melons and things than apples and pears. Sandwiches. Bread's like a 4-letter word to everyone here. But when you pick the right bread, and after surgery, you have a limited space. So I'll say Ezekiel 4:9, which is in your freezer section. Or there's a new one, Dave's Killer Bread. In your regular section, they have a thin slice. It's about 60 calories. But you could probably only eat a quarter to a half a sandwich. You do it that as a snack, you're under 100 calories. You're going to feel full for a long period of time with that. Lunch meat roll-ups are a good way if you're trying to avoid all the carbs. Protein bars, and we'll talk about these in a minute. Those can be a great way. Dr. Liao mentioned those as something to look forward to, less prep time and things. Nuts in limited amounts, tend to say almonds. And then there's all kinds of jerky out there. You have to be careful of the sodium, but you have turkey and beef and bison. There's all kinds of options, and those will tend to fill you up. And then meals. So this is the old Wendy's commercial, where's the beef? Well, that's kind of what we're asking. When you have a meal, where is your protein? Protein is the first thing you need to ask after you have surgery. What's my protein source in this meal? And you eat that first, because that's going to fill you up the most, and then you're going to avoid some of the bad things to bring in. And so those are our goals, these kind of snacks and meals. We want to focus in on that protein. Now, mention protein bars. Food industry is very clever at marketing. They know what we're after at any given time. It was low fat for a while, then it was low sugar. We see gluten-free now, and then you see high in protein. Protein, because you have Atkins diet, you have keto diet, you have post-weight loss surgery patients. You have lots of people who are looking for high protein. And so they'll market to that. And so you see certain protein bars, they say protein. But when you look at a protein bar, I want you to look at the calories. If it has 200 calories, you're going to divide by 10, and you want 20 grams of protein. If you don't get that ratio, then you're getting closer to a candy bar than a protein bar, and we want to stay away from that. And so that's what we're looking at for protein bars. To find good protein bars, you can supplement with the snacks. You want to avoid some of these light and sugar-free. I tell patients for snacks after surgery, if you can take a piece of something and hold it underwater and it goes to mush, that's all it's doing in your stomach. It is not going to fill you up. It's not going to satisfy you. You're going to be able to eat more of it. So all the chips and popcorn and things, it's just not going to satisfy you. We need to try to stay away from those and find things that are going to fill you up. Biggest things now, P3, these little protein packs. And the concept behind them is good. It's focused in on protein, but when you look at what they put into it, you're getting a lower quality meat. You can do better getting some chicken breast for yourself or some high quality lunch meat from the deli. It's got a high fat cheese, so you get more calories from the cheese than you need to. Usually they'll sprinkle in some cranberries and things like that. You get more sugar than you need to. And so you can kind of make your own versions of these and keep them a little bit healthier. So the concept is there, but not overall what we want in those products for you after surgery. The other area we hit problems, liquid sabotage. And so we all like to go and get our beverages, our coffee, and coffee's okay, but coffee with, the frappuccinos and lattes and all the sweeteners and, the venti side, we've got to kind of stay away from those. Smoothies, everyone thinks you can get these protein-based smoothies, but I can tell you if you walk into any smoothies place, you're lucky to get out of there under 400 calories. And when we're looking to keep you early on under 1,000, closer to 800 calories, that one smoothie is costing you a lot of calories for your day, and it's not going to sit with you very long. It just has a lot of sugar content, a lot of calories. Sweet tea. So sweet tea is a Texas thing. I'm an Ohio boy. That was not in Ohio, but that is a big culprit here that I hear from patients. And then soda, you're also wrong on that. It's called pop. Pop in Ohio, not soda. But that is also a big downfall. Carbonation and lots of things that go on with that, and the sweeteners. So what happens to you when you have soda? Because patients will say, well, I'm not going to have the carbonation. I let it sit and it goes flat. And so, that's okay, right? I can still have that. Well, it tricks your mind. So immediately the phosphoric acid in it starts attacking the enamel on your teeth. The aspartame or the sweetener starts tricking your mind into more of a sugars being in, and so it goes in kind of fat storage mode. And so it's telling your body to hold on to stuff that you're trying to lose. There's been studies showing that this causes addiction. The high levels of sweetness in it pushes your sweetness, your mind into wanting more and more sweet. And then it also starts depleting your nutrients and things like that. So overall, even though you might let the carbonation go out, which we don't want for your post sleeve or post bypass to put that pressure, a lot of the other components of POP we don't want in there either. Other keys, so exercise, it is not a 4-letter word either. You know, it's 8. If you want to say it's 2 4-letter words, okay. But we need to find something that works for you. And this is not one size fits all. Everyone has different limitations, but we need to find ways. You know, you don't have to be the bodybuilder, the weightlifter. Find something, yoga, the Tai Chi. You know, people will complain about the weather. Well, it's always 70 degrees in the mall or Walmart. You can get out and walk around. Start pushing your physical activity, and that's going to be a big key to success after surgery. Accountability. So accountability is the number one thing. And what are ways we get accountability? And so these people look a little too happy to be running. Maybe Dr. Bell looks that happy running. He's a runner, but I do not look that happy running. But finding friends. Friends will help you get to the gym and do exercise. It's real easy to quit on yourself, but if you have someone else there who holds you accountable to meet up to exercise, you have much more success following through on your exercise program. You know, Dr. Liao mentioned, you know, there's tons of apps. There's Bariatric Pal, MyFitnessPal, ways to track calories. It's not the most fun thing, but studies do tell us it leads to results. You have all the fitness trackers and things. You know, early on, you're really restricted, and your body knows when it's full. Later on, you can kind of start eating a little bit more, and you kind of start forgetting, what's my portion size? So breaking out that food scale and kind of checking, is my portion size right for me? Is this good enough? Because you know it used to be good enough. Is it still good enough for you? And how that. Other things, this is our calendar of events for our support group. Studies point to patients doing better coming to support groups in long term and being participants. You tend to maintain your weight loss better. You know, I do an online, because it's not always convenient to come in and meet. You know, I'll do online. I do Facebook chats for my patients on Tuesday nights. Come in and ask questions. We're always there to try to help you. And so we want to make you successful. And then pictures. Initially, when you have the surgery, people will be saying, oh, I can tell you're losing weight. And you look in the mirror and you're like, am I losing weight? Because you don't see it. You don't see it in the mirror, but when you take pictures, you see it. And so a lot of my patients come in, we take pictures together. And so we'll see each other in the hallway and kind of see over years. And, you know, you can see Dr. Henke's gaining weight or losing weight at that time too. So I get to see myself too, but, you know, it helps you see how you're doing. There's the quote, we have met the enemy, and the enemy is, well, it says us, but really the enemy's that thing. The scale, right? You never knew something that, you know, metal and plastic, it scares you. You don't want to get on that scale. But we need you to get on that scale because it's a way to track, you know, and I don't want you weighing yourself daily. You'll lose your mind weighing yourself daily. But we need you tracking once, twice a week. It holds you to that accountability to track. And, you know, no one else needs to know the number. You know, I need to know the number and when you come in. But this is not the only thing that guides your success. But it is part of how you track and keep yourself accountable through the years, is that scale. But, like I said, this is not the only thing that matters. Success after surgery is not defined by just the weight you lost, the pounds on the scale. It is the non-scale victories. And so you see the picture there, playing with your kids or grandkids when you were avoiding doing things like that. So being able to be more participant in your life and enjoy, you know, retirement if you're retired, enjoying the grandkids. You know, you had the deal of raising your own kids and the suffering. Enjoy your grandkids, you know, do the fun stuff with them. Patients coming in and saying, you know what, I can cross my legs now. I can't remember the last time I crossed my legs. As Dr. Bell mentioned, coming off medication, stopping your insulin, stopping your blood pressure medication, all those things are successes. Sleeping like a baby. You know, we see lots of sleep apnea, lots of people who say, I cannot sleep. And then they come over and have their surgery and say, man, I've had the best sleep I have had in years. The seatbelt, going on a trip and not needing the seatbelt extender on the plane. That's a huge victory for a lot of patients. You know, going to the mall and not saying I can go to this store Or maybe that store, you can walk into any store and pick out clothes at any store. So there's lots of different things that you can measure success with. It is not just the pounds on the scale. And so, we oftentimes say, well, I wish I would have gotten to this weight, or, I wish I would have lost that 100 pounds. I got to 95. Well, what else can you do in your life? What else has become better for you? And don't get discouraged just by those numbers. You want to find those things that have led you to be successful, those non-scale victories. And there's lots of lists you can have for yourself. And then here's some patients. So this is kind of patients in different spectrums, over the years and successes we've had. And I can tell you these patients don't just point, they feel great and feel good in their pictures and things, but they don't just point to, the pounds on the scale. In the corner, she does conferences for The Walking Dead. She goes to conferences and leads the actors around, is super active. She's like, I never would have done that. I never would have had the confidence to go meet with these people, walk around and interact with them. But I do all these things in my life that I never thought I would ever do. And so you look at those things as huge successes. And with that'll end our talks for today. But we'll all be up here and take any questions you might have.
Dr. Liao, I like to eat while I'm watching TV. How can I unlink that?
I think what you should do is, again, practice what we call mindful eating. So think to yourself, what do you like to eat? Go sit down at a table, put that food in front of you, smell it, taste it, and in your mind, realize that you're eating it. So it's not always going to be easy the first few times that you do that, because you'll say, gosh, I wanted to watch that TV show and I'm missing that show. What you have to do is realize that you are treating yourself and you're helping your mind to realize that it's eating. Because it's not just about what goes into your mouth, it's also what your brain is thinking that it's eating. So it's going to be hard the first few times, and it's really going to be boring for some people. But when you are conscious and aware of the food that you're eating, it helps.
With the sleeve surgery, with the, is it staples that you put in, do they dissolve? Do they leak later on in life? How does that work with the progression later on if you get the sleeve surgery?
So that's a great question, and the question was, is the operation done with staples for the sleeve, and what happens to them later on? So those staples are permanent. They're made out of titanium, and they're very small. They're probably about 1 millimeter in size, and there are 3 rows of staples on the edge of the stomach to prevent a leak. And so because the surgical staplers are so good these days, and so the design has been improved over the years, the chance of a leak is very low. And so long term, the further you get out from surgery, the lower chance of a leak also. So they're permanent. Once the stomach heals, that tissue grows over the staples, and they stay there for life. I've had some patients ask me if they would ever set off a metal detector, and they will not. They're very, very tiny. They're almost hard to see with your eyes, so that's a great question. I appreciate that.
Okay, and the balloon surgery, why does it only stay in there? The balloon is only in there for 6 months.
The balloon will degrade, and it's just not designed to withstand stomach acid for longer than 6 months. So you can take them out, and then you can put another set back in, but they're not designed to last longer than 6 months. So the one that Dr. Bell was describing is called the Obalon, and basically what it is, it's a big capsule that you swallow, and it's connected to a tube that's connected to a gas tank. So you swallow the pill, we take an x-ray, we make sure that it's confirmed to be in your stomach, and then once it's confirmed, we blow up the balloon with gas, and then the little catheter just pops back off. And the way the Obalon's designed, it's three balloons. So you do one, then you do one 2 weeks later, then you do one 2 weeks later after that. And then at the very end, when it's time to remove them, you do have to go to sleep for an endoscopy, where we put a camera down your mouth into your stomach to deflate the balloons and take them out. And there definitely are patients who have had that as soon as they take them out, they start putting new ones back in.
What is the balloon made of?
It's a form of plastic. I honestly don't remember what it's actually made out of. Not latex, no. So, and they are trying to design balloons that are dissolvable after 6 months, but those things aren't out on the market yet.
So I have a question. I'm 17 years old and my BMI is 28. What can I do to bring that down?
Well, I would say that because you're in a category where you don't qualify for surgery right now, it sounds like you're thinking about non-surgical weight loss. And so what we usually recommend is that you look at your diet first. Food is always the first thing that you want to look at. Activity helps, but it's not the main thing that drives weight loss. So it's different from one person to another, because sometimes we'll have people who have trouble with their sleep, and that needs to be fixed in order for them to be able to lose weight. Sometimes people will have trouble with their thyroid, and they're not aware of it, and we don't know until we check those labs. So there are a variety of things that can contribute to it. But if you are a generally healthy person who doesn't have any other medical problems going on, usually the first thing I would say to look at is your foods, and try to decrease the unhealthy foods, decrease the processed foods, take out the drive-through eating. And for many people, that already gets them started on the road to weight loss. If you have more specific questions, we can probably talk to you after this Q&A session.
So one thing I just want to add for that, is basically earlier is better, but it is never too late. So, all of the studies basically show is the earlier you decide on an intervention, whether it's diet, whether it's medicines, whether it's surgery, is people do better. And so it's fantastic. Everybody has taken a great step by coming here today. The key is take this information and do something with it. Don't wait 3 years, don't wait 5 years, don't wait 10 years. Because the trend is typically for most people is to gain somewhere between 2 to 3 pounds a year. If you're 20 years old, at age 50, what's going to happen? If you're 50 years old, what's going to happen by the time you're age 70? So, as I said, it's great that you're here. It's great that you're asking questions when you're young, but now is the time to do it. It's not to wait.
If you've been dealt an unfortunate hand genetically, is it even possible to lose weight?
Yes. So we definitely see, we definitely see clusters in families where, I've had a family where I've operated on the father and I've operated on the 3 sons. I think Dr. Henke's had that experience, and people can overcome that. I don't know.
So yeah, there's a lot of things. Obesity is misunderstood in a lot of ways. It's one of the biggest diseases that's just hugely stigmatized. But you're right. There's genetics. There's things that we see with gut bacteria going in, and so we know you have to have a lower calorie intake than anyone else losing weight, and so we look for the tools to do that. And oftentimes that can be surgery, it can be medicine, but long term, we tend to see, depending where you start, that be the best option, because your calorie intake, you go on MyFitnessPal and I calculate like based on average, expenditure, but really if you followed the same calorie goal as someone who hasn't struggled with their weight, you would be gaining weight, and so you need to be under 1,000 calories. It's really hard to do comfortably because of the alterations in hormones when you're losing weight, unless you have that tool. But it is possible with that tool to lose weight. Long term with medicines, you can consistently lose weight over the course of years. It won't be as dramatic, and you tend to bounce back and forth and fluctuate, and that's probably the hardest thing with diets. If you don't see continued success, it's really hard to stick with that program. And so you do get the unfortunate end of genetics and things like that at times.
Don't you think it's interesting, when you go to Europe, you go to France or Spain, the portions are smaller, and they take time eating like the meals like more of a social occasion, whereas seems like we're in a hurry.
And those people, I think they get a lot more exercise than we do. And the restaurants, a lot of the restaurants don't serve those big, huge portions. So why can't the restaurants here do that? They don't make as much money.
We do see that. I mean, America's always kind of been called the country of excess. I lived in England for a year, so I know exactly what you're talking about. It is a little bit more active lifestyle over there. Cars are not as prevalent, especially in big cities there, that you have public transportation, a lot more walking and things like that. But if you look at all the European studies, we're not the only country with alarmingly increasing obesity rates. The European countries are seeing the same trend as us. They're a little years behind us, but they are catching up to that trend as well. So it is not just the U.S., it is the European countries as well.
Yeah, I mean, it's a public health issue. If you remember back to the slides I showed you of the states, and if you look at the slides that Dr. Liao showed, a lot of the growth in obesity is related to the growth in changes to refined sugar, which a lot of it is corn syrup. So if you look at it and where subsidies from the government went to which food companies, et cetera, so a lot of it is driven by the government and who they're supporting and what they're supporting, et cetera, and then also with different recommendations from the government as to what diets people should eat. Because for the longest time, they encouraged low-fat diets. Well, low-fat diets had a lot of carbohydrates, and now it's starting to swing back the other direction. So there's not an easy fix for society as a whole. For everyone that's here has kind of been affected by that, but the hope would be is that we can help you, but then we can also make changes so that people who are younger than you can benefit from those sort of more societal changes. I'm going to give Shay a chance to speak. So Shay is our coordinator for the hospital. She is also a patient who has had surgery. And I'll just let her share a few words if she's got any words of encouragement or advice or anything.
Okay, so real quick, I just want to know what are other great sources of protein other than meat? If you're not eating beef, chicken, any of that.
So essentially, like, we have types of protein called high biological value proteins. So stuff like that would be your lean flesh meats, like your turkey, chicken, and your fish. Stuff that would be included in that would be all your nuts and your beans and your seeds, and also any kind of eggs. So if you like hard-boiled eggs, something like that would be good too.
Yeah, and just along those lines, we have had patients who are vegans, we have had patients who are vegetarians, so it is possible to get your protein from non-animal sources if that's the kind of diet that you have.
You mentioned artificial sweeteners is one of the issues with soft drinks, and of course that applies not only to Coke and Diet Coke, but to Crystal Light and those sorts of things. So is there any artificial sweetener that is less problematic than the others?
I actually don't encourage any artificial sweeteners at all, and different people may disagree on this, but artificial sweeteners affect you in several different ways. So it's not just that your tongue is getting this sweet flavor without calories, quote unquote. Part of the problem is that you're still getting a surge in insulin when you take an artificial sweetener, and it's that insulin signal that causes your body to get that signal to store fat. You don't want it to have that store fat signal. Another thing that happens is in the brain, you trigger additional cravings. So you might remember from Dr. Henke's slide that there was a little section on sodas or pop, and how the trigger of cravings in the brain is part of the difficulty, because then later on you're going to seek out another source of sweetness. And whether that happens in an hour, 2 hours, or whatever, you're seeking that out. Another thing that happens is that you change the gut microbiome. So we've all heard about how we have healthy bacteria living in our intestines all the time. And when you change the ratio of healthy to unhealthy bacteria in the intestines, it actually also changes your ability to absorb the calories from the food that you're taking in. And unfortunately, artificial sweeteners lead to a greater absorption of carbohydrate-type calories. They change the microbiome, and they also give your body some more signals to store food as fat. So unfortunately, I would love to say that there is a perfect artificial sweetener out there, but there's not. The best thing that I would recommend for people is to try to train your tongue in a different way. Think about cutting back on the amount of sweetener that you use, whatever type it is, so that your tongue gets used to not seeking out as high of a sweetness value.
What's the best natural sweetener?
I wish I had a perfect answer for that too. And this is also why I say that, you know, with some of these questions, you can have all of us in a room and we'll each give you a different answer. I don't think we're all going to find perfect agreement on what the best natural sweetener or even the best artificial sweetener might be. My best advice is to decrease your sweeteners, whatever types they are.
Honey and agave or do what? It is natural, yes. So depending on if you're diabetic, so that's why we can't give really general advice. So, I mean, if you're diabetic or if you're not diabetic, I mean, sugar affects everyone in different ways. So as a general rule, honey is better because it is, you know, more natural. But, I mean, it'll be tailored to depending on what other medical conditions you have going on.
The only advice that I can really give everyone, coming from the perspective of, one, I worked on the bariatric for a couple of years prior to actually deciding to do a procedure, you know, seeing what comes in, what goes out, kind of following people.
You need to put the microphone closer to your mouth.
Sorry.
I can't hear you.
Then also, at that point I decided I was going to go ahead and I had a sleeve done. It wasn't easy. I wouldn't at all. However, it was very rewarding as the weight started to come off. I began to work out more, going to the gym. I actually stopped going to the gym and actually work out outside, which was a little bit better. I found that I could do a little more. And then just watching what I eat. I had moments of plateauing, but then I just kind of revamped my diet and it started again. So I have not had any issues as far as any complications, and I have not regained anything, and it's been a little over a year. So, now I'm the coordinator, so we can all be friends. So my card is on the table. You can call anytime you want or email.
Okay, well, with that, we're going to conclude this morning. We'll all be around if you guys want to approach us individually. Grab a goodie bag. We all have our business cards sitting out on the table. Thank you so much for coming. This was great.